Good afternoon, and thank you everyone for attending today's webinar, Using Health IT for Quality Improvement and Reform, presented by David Ford. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located to the right of your screen. They will be answered in the order received during the question and answer portion. Additionally, an electronic version of this presentation will be emailed to all participants following completion of today's webinar, and a recorded version will be available on the website for members only. Again, we would like to thank you for attending, and I am now turning things over to David.
All right, thank you, Alex, and thank you to everyone who's made the time to be part of this webinar today. I will go quickly through my presentation. I do like to leave time for the discussion portion at the end. So, here we go. All right, having a little technical difficulty there. As Alex mentioned, today's presentation is Using Health IT for Quality Improvement and Payment Reform. I'm David Ford. I'm the Executive Director of an organization called CalHIPSO. And in case you are not familiar with CalHIPSO, just very briefly, CalHIPSO was founded through a joint effort of the California Primary Care Association, the California Medical Association, and the California Association of Public Hospitals and Health Systems. CalHIPSO was founded actually just 2 weeks ago. We celebrated our 10th birthday. And what we do is we help providers, especially in those settings, small practices, community clinics, public and critical access hospitals, to utilize health information technology in their practices. So traditionally, CalHIPSO was very, very focused on meaningful use and helping providers achieve meaningful use, access the Federal Electronic Health Record Incentive Program. And while we are still doing a little bit of that, we've also branched out into other directions. We are doing some practice transformation support for accountable care organizations. And we've also done some recent projects on quality improvement, on population health, and encounter data submissions. Across all programs in 10 years and now 2 weeks, CalHIPSO has provided technical assistance to just a little over 15,000 unique clinicians, most of them physicians, but also some dentists, some optometrists, a few others, across more than 1,400 organizations. And we've helped those providers earn more than $300 million in federal EHR incentives. So let's talk about, though, where CalHIPSO is going and where Health IT is going, because it sets up this whole conversation we're going to have over the next hour. So when CalHIPSO was formed 10 years ago, the industry, CMS, everyone was very focused on adoption of Health IT and getting convincing providers to adopt electronic health records and health information exchanges. And, you know, the most well-known way we were doing that was the Medicare and Medi-Cal EHR incentive program, which you literally were paying providers who adopted and started using an electronic health record. But that portion of our work is pretty much done, especially here in California, where I think our EHR adoption rates are, I think, somewhere in about the low 90%, depending on whose survey you believe. And the providers who are left, who are still paper-based, are by and large not going to adopt electronic health records. They're likely close to retirement, or for other reasons just aren't going to. So we've shifted off of the focus on adoption of Health IT, and nowadays we're thinking more about how to help providers utilize the Health IT that they've adopted. And so some really common ways that we're looking at that. Some of you may be familiar with a project that unfortunately has not started yet called CalHOP. That's the California HIE onboarding program. That is, when it starts, that will be a $50 million project that will help providers onboard to a health information exchange. There's the changes to physician payments that came in MACRA. And then, as we'll talk about later, there's a big move to value-based care and away from fee-for-service and volume-based care. So I want to touch on 4 big topics today that fit under this rubric of utilizing health IT. Talk about why they matter, what they might mean to your practices, and how you can get ready for them. So we'll talk a little bit about health information exchange and some upcoming state funding. We'll talk about changes that are coming in quality reporting. For those of you who are active in the Medi-Cal program, that's the section, by the way, that you really want to pay attention to because there's some big changes coming in the Medi-Cal managed care world. Opportunities to use health IT to engage in payment reform, such as accountable care organizations. And then I would be remiss if I didn't talk about one issue that's kind of hanging over everything right now, which is interoperability. And I'll talk later about why that matters so much. So let's talk just first off about health information exchange. And I could give you a basic 101 about why health information exchange is so important, but instead of doing that, I just cribbed directly from the Federal Office of the National Coordinator for Health IT. And the basics of it is, by getting the right data, you can provide better care. Avoid readmissions, avoid medication errors, improve diagnosis, and I think probably most well-known and most importantly, decrease duplicate testing, because you'll be able to see what tests have already been done by other providers who are seeing the same patient. And so if you haven't engaged in health information exchange before, possibly the best use case and the most common one that's discussed is what's called an ADT, or an admission, discharge, or transfer. And an ADT message is, as the name describes, it's simply a message to all of the patient's known providers that one of those 3 things has happened. Either the patient has been admitted to a hospital, discharged from the hospital, or transferred to a different provider. And I mean, for those of you who are in medical practices, the reasons for this, I think, are usually pretty obvious. Is it allows you to follow up with your patients or to coordinate their care. So for, sort of classic example is a patient ends up in the ER and ends up admitted to the hospital, and there's a case, if there's a health information exchange present, then the hospital can send a note out to that patient's primary care provider, who very likely is outside the hospital, and say, hey, are you aware this happened? You might need to follow up with this patient and find out what happened. And that provider can also know what happened while that patient was in the hospital to know what things they should be looking out for on the next visit. So traditionally, ADT messages have only been used within closed systems. In, a Kaiser, a Sutter, a big hospital system that's integrated with primary care, where they can send the message in their own system. But the advantage to having a community health information exchange is that through that HIE, the ADT messages can go outside the walls of the hospital and can go out to community providers. In some instances, and this is a developing piece, so I don't want to get people too excited about this, but occasionally those ADT messages are actually sent outside of healthcare providers altogether to other care team members. So there might be cases where a similar message can be generated that goes to the patient's family, that goes to a home health worker, that goes to people like that who are part of the care team, to let them know what things they should be looking for and they should be following up on when the patient comes out of the hospital. All of that's possible through a health information exchange, and it's why this is so important. And that's just one really well-known use case. So, unfortunately, here in California, health information exchange has been somewhat slow to take hold. We do have some places where it's been really, really successful. If anyone's listening in from, for example, San Diego, you guys have a wonderful community health information organization down there called San Diego Health Connect. Santa Cruz, for example, has the longest continually operating health information exchange in the country. But there's still large swaths of the state where many, many providers who are not connected. And so seeing that, about a year and a half ago, CalHIPSO joined with our partners at the California Medical Association, Blue Shield of California, and a whole bunch of other similar organizations. And we went in and did a little old-fashioned lobbying in the Capitol. We convinced the state of California to put up $5 million in the 2018-19 state budget for HIE onboarding. And so under what's called high-tech 90-10 dollars, that $5 million will be matched 9-to-1 by the federal government. So $5 million state dollars, $45 million federal, and we get a $50 million health information exchange program. Now, this is the unfortunate part. I had hoped by September of 2019, I would be able to tell all of you guys, this money's flowing, go out and get it right now. Unfortunately, that is not quite where we are. The process of negotiation between the state government and the federal government has not gone as quickly as we would have liked. The State Department of Healthcare Services is currently working to secure federal approval of this project. Last we knew, the Department of Healthcare Services had sent what was hopefully their final response to federal CMS, and CMS had a 60-day clock to respond that should expire somewhere at the end of this month or the beginning of October, which hopefully will allow the program to begin somewhere in late 2019. The issue is once this money starts to flow, it's going to have to flow really fast. Because these are high-tech 90-10 dollars, that line of funding expires September 30th, 2021. So it's not just that the program needs to be approved before that date. The program needs to go through its whole life cycle of approval, implementation, and wrap-up by September 30th, 2021. So when it happens, we're going to have to move really fast. Generally how it works, some of you who are on the phone who are in medical practices, you may have already actually been approached by your local health information exchanges and asked to sign a letter of intent with them. That is because when the money is approved, the HIEs are going to have to go to the state with a project plan that lays out how many providers they think they can onboard and what their funding request is. And the funding will actually flow through the health information exchanges. So instead of you paying them and them paying you, the money will just flow from the state to the HIE to defray your cost of joining on to the HIE. Some steps you can take now. I encourage everyone to look up what is called C10 participating health information exchanges. C10 is the California Trusted Exchange Network. It is a group of HIEs and some other folks who basically have signed what's called the CalDERSA. So they've all signed an agreement that they will all work together to promote data exchange. It is not 100% certain, but very, very likely that in order to qualify for the funding under CalHOP, providers will have to sign up with a C10 participating HIE. And I put that web address up on the screen. And as Alex said, this will be mailed out, so don't try to write that all down really quickly right now. But when I email this out, you can take a look at who those folks are. And for medical practices, if you're going to go down this road, I cannot stress enough, get your project plans, get your budget, get your internal timelines, all that stuff working now in advance of federal approval. We're hoping to be able to turn the key pretty quickly when that federal approval comes. For more information, as I say, this ball is really in the court of the Department of Healthcare Services right now. They do have a CalHOP portion of their website that is up and operating. So you can write down that big URL, although I do also happen to know if you Google DHCS CalHOP, it's the first thing that comes up. And there's some more information on that website about how the project's going to work. They've done some webinars, some public presentations that they posted on there that so you can see for yourself some more information from them about how this is going to work, with the caveat that everything is still subject to federal approval. So that's on Health Information Exchange, what I would recommend everyone be thinking about right now. Second, talk quality reporting a little bit. I put this logo up on the screen because, yes, my last name is Ford, and so pretty much every day of my life I get jokes about how are you related to Henry, what kind of car do you drive, et cetera, et cetera. So rather than fight it, I kind of roll with it. And in this case, it works really nicely. Hopefully you all remember the advertisements, quality is job one. So as I mentioned earlier, in this case, I'm going to focus on one payer because there's something going on right now that I think everyone needs to be aware of and start to think about and adjust accordingly. So let's talk about Medi-Cal. And, traditionally, I think we've thought of Medi-Cal as a program, just for the indigent and the uninsured. After the Medi-Cal expansion under the Affordable Care Act, Medi-Cal now is comprised of 14 million patients, or a little more than 1 out of every 3 people in the state of California. So it's one payer, but it's the biggest payer, and it's a big deal. So as I'm sure all of you know, for the most part, Medi-Cal has now transitioned from a fee-for-service, traditional fee-for-service government-run project to one that has been devolved out to the Medi-Cal Managed Care Plan. And there's several big things actually going on in Medi-Cal Managed Care right now, but I'll focus on this one for right now, which is that Medi-Cal actually announced somewhat quietly this year that they are changing all of the rules around the quality reporting that the plan has to do to the state in Medi-Cal Managed Care. And it's based on direction that came down from the federal government, but DHS is moving from what's called the HEDIS measures to the CMS Child and Adult Core Measures set. That is a much larger, much broader set of measures that the Medi-Cal Managed Care plans are going to have to report to the state government. Now, not only is the state asking the managed care plans to report on a broader set of measures, they are also asking them to significantly increase their performance. So traditionally in Medi-Cal Managed Care, the minimum, what's called the MPL, the minimum performance level, was that a Medi-Cal Managed Care plan had to be in the 25th percentile nationally on all of their quality measures. Now, the Medi-Cal Managed Care plans have to be in the 50th percentile, which means they, as it sounds, they have to double their performance overnight. And well, that just summarizes the last thing, but basically overnight, many more measures and a huge increase in their performance level. Now, combine that with next year, the Department of Healthcare Services, for every county where there are private managed care plans, so every county that's not in a county organized health system, the state is going to do one big procurement, what we're referring to in Sacramento as a big bang procurement, for the whole state next year. They're going to release the request for proposals sometime in 2020, and as you see, the implementation dates are either January 2023 or January 2024. So this is a lot of change all at once. And those two things, the huge increase in the quality performance and the procurement, may not be directly related, but I think, especially from the plan perspective, they're being seen as very related and very interconnected. And so this is going to create an enormous amount of pressure on the private managed care plans to do a lot of work really fast in their quality reporting. So that's all what the plans are dealing with, but as we know, the only way a plan increases its quality measures is to coordinate better with the providers who are in that plan's provider network. And the plans are already talking a lot to CalHIPSO and to others about the need to get much more and much better data than they are currently getting from providers. And especially, I think the providers that CalHIPSO has traditionally worked with, the ambulatory providers, the community health centers, it's often, what we've discovered is it's often not a matter of that providers are not doing the right things or that the plan's getting data and it's bad. What it tends to be is that the providers actually are doing all the right things, and it's a matter of how they're packaging it and reporting it to the health plan, if they're reporting it at all. And of course, in the quality reporting world, no answer is a wrong answer. So this is going to create a heightened level of scrutiny and heightened demand for data from the plans to the providers in their Medi-Cal networks. So let me give you a real-world example of how this sorts out. And this is actually a very real-world example because it's something that CalHIPSO saw in one of our projects that happened to be about getting providers to report better diabetes data. So this was a clinical workflow that CalHIPSO saw. Practice referred a patient to an outside lab for an A1C screening, which is pretty common in a smaller practice that doesn't have an in-house lab. The lab would fax back the test results to the practice. A medical assistant would scan the results into a PDF, and the PDF was attached to the patient record in the EHR, but no structured data was reported. Now, in this case, what the health plan saw when they looked at this provider was that this provider's diabetic patient had never received an A1C screening. And this provider ended up on the proverbial naughty list of providers who weren't providing good diabetes care. When our practice coach went in and did a chart poll, she ended up very confused because in this case, literally 100% of this practice's diabetic patients had a recent A1C screening in the timeline. So, to-dos, and I'll take these a little out of order from how they're presented here. But one thing we always want to remind people when you're dealing with electronic health records and digital data is the only data that counts is structured data. Data that is entered into the EHR in such a way that it can be searched, aggregated, and most importantly, reported. So PDFs, scans, those things, they're fine. But remember, it's not structured data in the EHR where most people are concerned it doesn't exist. And going with that, number 3 on here is to make sure that that's clear and that your clinical workflows reflect that reality. We also, skipping back up to the top of this slide, if you are in the provider network of a Medi-Cal managed care plan right now, it is a good time to get on the phone with that plan, talk to their quality improvement folks, talk to their provider relations folks, and find out what data they need. And if they'll give it to you, how you look on the measures that they're going to be reporting on. Because, as I said, they're going to be very encouraged and very hot to talk to you because of all this other stuff that's going on at the state. And it's time to open up that dialogue and sort things out. If, as many of you probably do, you contract for Medi-Cal work through a group or an IPA, it's also a good time to talk to them and find out if they're aware of this and if they're having the conversation with the health plans about all the changes in quality reporting and making sure that they're reporting the correct data to the health plan so that you don't get caught because an IPA that you contract with didn't report your data correctly. And then one last thing, proper coding, and I will talk more about this in the next section, but proper coding is everything in health IT. and making sure that all of your coding is up to date. We have found through doing projects in this vein that ICD-10 and CPT2 coding was actually where a lot of providers were getting tripped up. And in the logic of some of the computer systems, again, an improper code or an out-of-date code just comes back as an error, and it comes up as a wrong answer. And providers end up, again, on the quote-unquote naughty list simply because their coding is a little bit out of date. So you've got to double check all that, make sure, and if you're relying on your HR vendor to handle this for you, make sure you're talking to your HR vendor and make sure all their coding is up to date and up to snuff. Because sometimes that may take an opt-in or an upgrade to the system or a new module to make sure your coding is up to date. But all that is very, very important, so you don't end up in the situation that the provider I described before ended up in. So, and once we've gotten through all of that, you're ready for what we at CalHIPSO sometimes tongue-in-cheek refer to as the graduate level course, which is beyond all of the data capture, all the quality reporting, all the data exchange. Once you've got all that working, then it's time to start talking about how you engage in new models of care and new payment and reform models. Payment reform is really a catch-all term. And you'll hear a lot of things referred to as payment reform. And actually, each of the things I listed up on there, even within each of those, there's a lot of different versions of it. So I think the one that probably has the most cachet right now is Accountable Care Organization, which also might be you might hear referred to as MSSP, or Medicare Shared Savings Program. But even within accountable care organizations, there's different forms because Medicare started it, but of course others are picking it up. So there are also commercial ACOs that are organized by private health plans that may look very different and have very different sets of rules. And all generally work on the idea of shared savings, but can be very, very different. I'm sure many of you are familiar with health plan pay for performance programs. One of the things that underpins almost all of them is population health, and that's generally just looking at patients in groups by population. So asking your EHR, for example, show me all of my diabetic patients and when their last A1C screening was. So that sort of thinking of looking at patients in broad populations is referred to as population health. And then there's sort of probably the longest standing and most well-known one, which is the patient-centered medical home. But while they have different names, and they are in some ways all very similar, and what they all have in common is that they're helping providers move away from the traditional pay for volume, and that volume of services, and that what we would sometimes, when I used to work for the medical association, we would refer to as the hamster wheel of productivity, and moving away from that to paying providers based on quality of care and outcomes reported. So generally the transition away from fee for service. Another thing though, for what CalHIPSO does and what this webinar is about, is to remember that health IT is a central component of all payment reform models. In fact, many of them, in the Medicare Shared Savings Program, the Medicare ACOs, is actually a requirement that believe that more than half of the providers have to be meaningful users of an electronic health record. And while that's a requirement, it's also an opportunity. Because what health IT really does, or what it can do, is it can actually, I term, democratize payment reform. So ACOs, and we'll just sort of stay on that one. ACOs, especially when they first came out, were very much the province of large medical groups and big hospitals. And that was because they were the only ones that had the care coordination staff, the population health tools, the payment, the billing systems to manage the risk, and the infrastructure to really support something like an ACO. Properly implemented health IT completely changes that equation. And it makes payment reform available to smaller practices that don't have that level of infrastructure or that level, those level of resources, because it makes those same tools available in, sort of smaller and less expensive chunks. And, through properly implemented data sharing tools, providers, where once I think we would have thought that providers in the payment reform model all needed to be under the same roof or in very, very close proximity, now providers can literally be anywhere, as long, anywhere with a good internet connection, and broadband capability, and there are ACOs that spread across state lines, that spread nationally, and the providers can still coordinate care because through health information exchange tools and through shared population health platforms, they can still manage their patients remotely and across great distances. So here's an example. This is sort of just a nice cartoon description of what an accountable care organization might look like, with the primary care payer partners. This is more of a commercial ACO setup. SNFs, disease management, population health, specialist, hospital, all the folks who might be involved in an accountable care organization. Just basics of an ACO. I think many of you are probably familiar with this, but under the Medicare version, which is the most prominent, most well-known one, groups of providers agree to manage the care for at least 5,000 Medicare patients. The providers work together, they coordinate care, they share data, and their whole goal in life is to reduce costs for that set of patients while providing better care, because that's actually how the ACO makes money, is that they save CMS money, and then depending on how much downside risk the ACO is willing to take, Medicare basically says, you save us money, we'll split the difference with you. As I mentioned earlier, there are many commercial versions of this supported by private health plans. They look very different. They all sort of follow this model because this is the Medicare model. So here's a whole different version of how an accountable care organization could work. 3 independent providers, disparate, again, don't need to be in the same community, definitely don't need to be under one roof, all sharing one online population health platform. That, as I say, is the key to everything. They can coordinate care through that population health platform, which will interface with the EHR and help them look for things like who needs follow-up care, who's taking their meds, all of those things that are involved in care coordination. Who needs to come in for an annual wellness visit, and these providers could be solo docs in small practices across great distances from each other. For example, in this case, this provider could be in Los Angeles, this one could be in the Central Valley, this one could be in Sacramento. Doesn't matter. And I already sort of touched on this, but through data sharing and Pop Health, here's some things you could see. Which of their patients has not been seen recently? That's important in a Medicare setting, where you can actually bill for annual wellness visits and where they're important for coding patients correctly. Who's been in the hospital recently? Remember all the way back when beginning of the presentation when I was talking about ADT messages? They are lifeblood in an accountable care organization setting, because, as I think we all know, proper follow-up care when a patient's been seen in the hospital lowers the risk of the patient having to be readmitted and all of the expense and the time that goes with that. Who's due for lab work, proper risk coding, are patients appearing to be healthier than they are, very, very common in Medicare and very, very important in your EHR, that your patient's risk scores are calculated appropriately, and many more. So all of that are things you can be working on, and I'm going to shift gears for number 4, because this is the one place where I'm going to talk a little bit about public policy and just one big issue that's hanging out there that has been the focus of a lot of attention recently, and that's interoperability. And interoperability and the move to increase interoperability is essential for all of health IT. Will make everything I've described to this point work. And that's why it's been a focus across policymakers, both back in Washington, D.C. and here in Sacramento. So it's a big, 10-cent word, but basically all we're talking about when we refer to interoperability is the ability of EHR systems and other health IT systems to communicate with each other. And while that may sound complex, it's generally mapping out things like, if provider A has a system that calls first name, provider B has a system that calls it F name, and provider C has a system that calls it first dot name, we can put up there on the screen, then you need a map, essentially, that tells all three systems, hey, this is all referring to the same thing. David should be in all 3 places. And the lack of interoperability has greatly plagued the spread of health IT from the very beginning. And I mean, I'm sure that many people on this call who are in medical practices have had the experience of, you have an EHR, you want it to either integrate with your practice management system, you want it to integrate with your billing system, you want to connect to an EHR, and either your vendor tells you we can't do that, or tells you, yeah, we can do that, it requires a custom interface, and by the way, that's going to be, a bazoodle dollars. So that has just been difficult from the very beginning. And there's a bunch of reasons for this. Some of them are technical, but some of them are actually just competitive. The federal government has been very focused on data blocking, where players in the marketplace intentionally block data to try to keep their providers from, or try to keep their patients from going and seeing other providers. There are competitive issues at play. Sometimes providers don't want to share data with each other. And then the very real and very legitimate concerns about patient privacy. As I mentioned, there's been a lot of action at the federal level, especially in the Trump administration. This is something that CMS and the ONC and the Trump administration has been very, very focused on. They've actually renamed meaningful use as promoting interoperability, or you may hear folks in my world refer to PI. And the way we used to say, well, are you MU compliant? Now we might say, are you PI compliant? Generally the same thing. It just has a new name to reflect the focus on interoperability. CMS has published 2 drafts of a document that you might hear referred to as TSCA, the Trusted Exchange Framework and Common Agreement. And that's because healthcare didn't have enough acronyms, so we had to introduce a new sort of difficult and convoluted one. So there you go. That is actually a long document laying out a general agreement for organizations that are going to exchange data on how they're going to do it to make sure that it's done as seamlessly and as efficiently as possible. Now, going with the 2 drafts so far of TSCA, there are also pending regulations. I think we're expecting to hear a about a final rule any minute now from both CMS and the ONC on data blocking. So it's interesting the way that if you look at these regulations, it's almost backward from what you would expect. In general, data blocking is illegal. What the regulations do is go back and say, okay, there are legitimate reasons for data blocking, and these are what those legitimate reasons are. So it reads a little backwards because the regulations say these are the sections, these are the reasons you're allowed to do data blocking. Which doesn't make a lot of sense until you know it's generally illegal, what they're providing are exceptions. There is this healthit.gov website on information blocking. I didn't want to put up too much information on this slide because these rules aren't final. And so obviously I don't want you guys running off and doing things or quoting me, and then a final rule comes and changes something that I put up on the screen. So, but be watching for these final rules because they're important. Going with that, as I mentioned, there's actually there's action in Sacramento on interoperability as well. Senate Bill 441 referenced here on the screen is actually a piece of state-level legislation. We believe actually the first piece of state-level legislation might be in the country solely focused on interoperability. It was sponsored by the California Medical Association, who is making a very good faith effort to advance interoperability in the state because they got tired of hearing the horror stories from their members, is really what it came down to, of the difficulties with data exchange, the problems with interoperability, the expense that comes with it. They heard too many of those horror stories from too many doctors up and down the state, finally decided they were going to make a move on it. Now, unfortunately, what's happened in this year is that the bill kind of stalled out because the plan that CMA had was to pick up where the federal regulations left off. And so what was the undone work? What enforcement could we create in the state? And really the lengthy delays in the final version of the federal rules kind of made the timing not right. But I have heard the CEO of CMA say many times in public, it will come back next year. It may not be called Senate Bill 441 next year because it may, for the logistical reasons of the legislative process in Sacramento, it may be picked up in a different piece of legislation that's introduced anew in this coming year. But be watching because something is coming, and I think it has the possibility of being a really important bill for how Health IT rolls out in California. So with that, it looks like we've got about 15 minutes left. I hope you've enjoyed the presentation, and as Alex said earlier, you can enter questions into the chat box on the right side of your screen, and I will be happy to take a few questions.
Again, if anyone has any questions, you can type them in the question box. We don't have any as of yet, so we'll just give a minute or two just to see if any come in.
You know, Alex, I know my experience is that usually the number one question is, will the slides be available later? And you already answered that, so maybe we headed off a bunch of questions ahead of time.
Yes, so if there are no questions, then unless you have anything else, we can go ahead and wrap up, and we will send out the slides afterwards, and they will also be available on the website behind the members only section.
All right, and if anyone thinks of questions later and you want to email me at david@calhipso.org, feel free to. I would love to hear from anyone with thoughts and opinions and questions.
And I'll add David's email address to the email with the slides as well, so you have his contact information if you do have any questions. All right, everybody, thank you for attending and have a great day.
Thank you.